So welcome everyone to our second Q&A session on exercise. As mentioned in my first session, I know not a lot of you really loved the fact that I gave a PowerPoint presentation for my first Q&A session. My mother let me know that she wasn't impressed with my first Q&A session and thought that I should be on camera the whole time. So I'm not much for being on camera. So I brought Keenan up here for moral support. And the thing is that I grew up watching these videos with an awesome director of personal training with the National Academy of Sports Medicine, and later went on to RTS, and so I'm never going to do justice to what he did with regards to his video series. This isn't a video series to go out to the general masses. This is just a video series for my clients. So it's not going to be a studio produced Q&A session or series. So today, what we're going to talk about is we're going to talk about some of the exercise questions that I get through email and their relative relationship to what occurs when people are coming in to see me for applied kinesiology therapy. So I'm going to introduce you to Keenan, and Keenan is studying Chinese medicine, and he's in his second year. It's been a great fit for me to have an assistant who has a real vested interest in the subject matter, not so much around exercise, but for his own personal interest around exercise, but more for the effects of exercise on the human condition. And this is something that we interact with on a daily basis during clinical hours. So Keenan's got some questions for me and from your emails, and so I ask you to send me your emails because there's lots of interesting questions. I'm going to try to keep it as basic as I can, and not get into too much elaborate type of exercise analysis because we don't have the tools. But I hope with the video feed that we have that you can see the analysis that we are trying to forward to you.
Okay, we did have some great questions sent in through email, and if you do have any questions, you can send them to scottforhan@rogers.com, and we will answer them on upcoming web series. All right, so the first question we have here is, what is better for strengthening my son's legs for hockey? Squats, walking lunges, or leg extensions?
Okay, so this is a question that I get all the time, and I'm surrounded by this this question really, because I have two sons that play hockey in AAA, and pretty much in every center where there's multiple rinks, there seems to be a type of an institute or a high performance training site where I walk by or I look in and I see kids with weights performing walking lunges, or in the squat rack performing squats. And you know, last year when I was in the gym, leg extension machine was another tool that young people were tending to use to try to increase the size of the musculature in their legs. So the most important thing that we need to discuss when we're discussing an exercise is we need to discuss the joint structure and function. So the most important thing when we're talking about joint design is that we realize that the knee is a hinge joint. Okay? Although when the knee is bent, it has the ability to rotate on an axis, okay, for medial and lateral rotation of the foot, the knee's primary function is that of a hinge. Okay? So if I turn that sideways and I show you, this is something that we're all familiar with, okay? Some things that need to be taken into consideration when we're talking about design. When we look at the femur, what I want you to draw attention to is first is the patella, so your kneecap. So the kneecap is supposed to maintain a central position with regards to this femoral notch that you can see that it fits right in here. So the kneecap's tracking is supposed to maintain itself over top of the tibia, okay, and over top of the first and second toe as the knee is bending and the foot is underneath, okay? So one of the simple rules with regards to bending the knee under load is that we want to line up the kneecap so that it is straight in line with the shaft of the tibia, and that we can use a marker for our first and second toe so that the knee is bending with the foot directly underneath the patella. What we want to avoid is having the knee bending and having the foot angled either medially or laterally while this knee is bending. Something that I see all the time, especially with lunges, is because the body is moving forward, what's happening is these kids' foot is hitting the ground, and once the foot has hit the ground and their anterior force, the force of their body coming forward, has reached the end of the amount of range of motion for the tibia to flex on the foot, what happens is I see that the knee typically goes to the inside, and therefore they're losing the position of the patellar tracking through the joints. And this leads to medial collateral ligament shear. Okay, so what I want to show you again is we have the quadriceps tendon, which comes down and comes across the patella, the kneecap. So the kneecap is underneath there. Comes across the patella and then attaches down into the fibula. Into the tibia. Okay? And then we can see that inside the joint, if I take this guy out and I look inside the joint, we can see that there is a meniscus, okay, which is like a shock absorber. So this shock absorber has these two receptacles for each of the condyles of the femur. And this is so those femoral condyles maintain their tracking on top of the tibia, because the tibia is just a flat surface. And so what we want to have is, like in the shoulder with the labrum, we have a meniscus, fibrocartilage in the knee that maintains the tracking for the femoral condyles. And you can see that the meniscus runs all throughout that contact surface area for where the femur will flex on top of the tibia. You can see they show a medial collateral ligament here. They show the posterior cruciate ligament here attaching onto the back of the tibia and into the joint of the femur, onto the femur. And then you can see, if you pull the kneecap away, at the attachment of the anterior cruciate ligament as it attaches to the front of the tibia and then back onto the condyle in the femoral notch. So what happens is those ligaments are there to check the amount of shear that this femur can produce as the knee is bending, either when the knee is hyperextending or when the knee is hyperflexing. Okay? So the most important thing is that when we're bending this knee, we want this kneecap, when under load, to be in line with the tibia and the foot that's below. Otherwise, we're going to get bending of this knee where there is what we call a valgus knee position, or the knee is bending inwardly, which is putting shear on the medial collateral ligament and creating strain within the meniscus and can even lead to injury. So the question is, what is the best exercise with regards to training for strength for the leg muscles? Well, typically what we're talking about when we're talking about leg muscles is we're talking about the quadriceps muscles, okay? And so the thing that I want you to realize is when we're developing the quadriceps muscle, okay, and we're dealing with a walking lunge, the human's weight is moving forward, okay? So as the human's weight is moving forward, then we're asking it to also hit the ground and then stop, and then allowing for that forward movement, which is already going to be bending the knee, okay, to then accept whatever load force is being held by the human, whether the position of that force is up on the shoulder or the load is dumbbells in the hand. That gravity increase in force that's going through the human is being coupled with the forward movement and speed of the human. So what happens is the foot hits the ground and then the knee flexes, okay, as the tibia comes to its forward position, its anterior position where it's running at a joint range of motion. The knee will be bending and bending and bending, and the anterior force on that femur is going to typically having it so that it wants to shear past the tibia. The tibia is stuck, and so the only thing that can bend is the knee and the hip. And so if I come back here and I show you this again with the foot hits the ground, and the tibia flexes forward to its maximum range of motion, runs out of that range of motion, and the knee has to bend, and based on the velocity that the person is traveling and the amount of load will determine how much force is going into this joint. The thing that's really important to understand is that because there's a forward motion, that means that the femur is actually trying to slide past the tibia. So the force that needs to be taken into consideration that's significant isn't so much the compressive force of the load, because there is forward movement. So with forward movement coupled with the compressive force of the load, we're actually going to be dealing with an increase of shear more than we're going to be dealing with an increase of compression. If this foot was stationary and the person was bending, perhaps doing a stationary lunge, we would still have shearing forces, but because they're not walking, we wouldn't have so much shearing forces relative to the speed of movement. We would just be dealing with a more normal amount of shearing force and compressive force together if the foot was fixed and we were doing a stationary lunge. So something that takes away having this anterior shearing force stressing against the cruciate ligament and the meniscus is to have the person step back and bend at the hip and perform a backwards lunge, which takes away the velocity of the shearing force, or takes away the velocity and reduces the amount of shearing forces in the knee, performing a backwards lunge. So walking lunges, probably not so fantastic. unless they're started with baby steps and they're started with just body weight. The most important thing for young people who are still in a pubescent state where bone is still growing is not to put an enormous amount of shearing forces or even compressive forces on that epiphyseal area, that growth plate. So the ideal situation is to start with a stationary lunge, practice knee tracking control, right? So that the motor program that they're installing is based on success. So if they can just have a stationary foot and practice bending and maintaining optimal alignment of the patella through the foot, then we'll have less injury going forward. The most important thing is as they're progressing is that progression, whether it's an increase of load or it's an increase of velocity going forward, is based on maintenance of alignment. Okay, so that's kind of my rundown of stationary lunge. The next one that is considered even perhaps more than the stationary lunge is the squat. So I don't know if you can see this really clearly, but I kind of drew a squat to show that we have to consider basically three lever systems. The first lever system we have to consider is the tibia on the foot. The next one that we have to consider is the femur on the tibia. The third one that we have to consider is the spine on the femur. So what's going to determine how much load is going through each of these joints is going to be how much range of motion each one of these joints will go through under this load. So for example, if my tibia is much smaller than my femur, then what will happen is my tibia will run to the end of its range of motion, and my knee, because my femur is much longer, will continue to bend, which will tend to have the person pick up their foot, as in this situation over here. The things that I see in the gym that are generic tendencies, kind of generic rules that I see that go through all kinds of teams, is that they'll tell these athletes that it's imperative that they bend their knee to parallel, okay? And so that can lead to problems. The reason why is because we have to consider three folding levers. Now, if the femur and the spine are the same length, then what's going to happen is when this person folds, this spine is going to try to keep up with this femur, and the body is going to fold forward. The hip is going to go back, and the force of this load isn't going to be so much through the spine, it's going to be across the spine. And so as load is going across the spine, we're going to be dealing with shearing forces that are across the vertebrae. And when we get down into the pelvic area here, when the person is bending forward and the spine is trying to keep up with the femur, when they get down to parallel, what happens is the pelvis goes into a posterior rotation, which puts an enormous amount of compressive shearing forces on the lumbar discs. And so the idea that building strength has to do with having the femur come to parallel isn't relative, because it has nothing to do with the proportions of the individual joints of a given person. So everybody's tibia, femur, spine relationship and their dimension is going to be slightly different. So there's no way that we could have a generic method for squatting for a team. So every single person needs to be evaluated for how their body bends. We could simply measure their tibia relative to the femur and the spine, or we could simply also just have them bend and see when their tibia runs to its end range of motion relative to the foot, how the knee is going to then fold. Is the hip going to shift back because the femur is very long, or if the femur is shorter, they're going to be able to maintain a knee bend and have a balanced amount of force between the knee and the hip, or maybe they're going to have a long femur and an equally long spine, and when they bend, the force is going to be all into the hip. So the line of force and its distance to the axis will determine how much force is at the axis, how much torque force. So the thing is, in this one, you can see that this line of force, because the spine and the femur are folding against each other, because there's a short spinal complex, we can see that there will be more torque at the hip. So this is something that we need to consider with regards to squatting. Squatting, when we're dealing with young people, should not be done with load. What we need to do is we need to be able to teach them this motor pattern, this skill, just like any skill that they learn in sport, and let them master the ability to control where they want the force throughout the range of motion. If I have somebody that has, a relatively balanced length between their femur, their tibia, and their spine, they can still choose where they want to emphasize the line of force as they're bending. They could decide to bend more into the hip and emphasize the glutes, or they could decide to bend more into the knee and at the ankle and emphasize more load in the femur. The key thing is we need to analyze what their individual ranges of motion are going to be during a squat, so we can ascertain where the limitations to how much range of motion should be set up for them, for their safety. And so this is one of my major concerns with squatting. Okay. The last question was with regards to leg extension. Okay, so the last consideration for exercises for the knee was to discuss knee extension. Okay, so oftentimes you're introduced into the gym, you're taken through the rows of machines that you have an opportunity to work with. You're brought to the leg extension machine. The trainer or the person who's familiarizing you with the device has you slide into the device. They put the pad above your ankle in the front of your lower shin, and they select something arbitrarily what they feel would probably be light for you, and you perform a knee extension exercise. So the thing that I want you to understand about the knee extension exercise is that what we're dealing with the quadriceps pulling its tension across the patella, and the patella is acting like a pulley. Okay? Because the patella is away from the knee joint itself, it distracts the forces of the quadriceps pull away from the knee. This is important because it gives the quadricep more of a moment arm for pull, greater mechanical ability to move the tibia through knee extension. Okay, so the thing is that the tibia is going to move around this condyle and come into a fully extended position below the femur. As it's doing that, the quadricep is pulling, and its force is coming away from the joint. So if you look at this diagram, you can see that we have the force of the muscle when you're in the bent knee position. This would be the pad. This is your femur, hopefully lining up with the axis of rotation of the lever arm of the device, the resistance arm. And once you're in that position, the forces that are acting against, so equal and opposite to the tibia, because of the patella being skewing the force away from the joint, it's not purely linear through the joint. It's actually the muscle force is skewed slightly away from the joint. As a result of that, the resultant force that's coming in is compressive, and the other force that's present is shear. So at no time is there not a shear force across this condyle. And there's nothing wrong with shear. Shear is opposing forces in opposite directions. The thing is what is the amount of shear? What is the distance of the load away from the joint? The further the distance the load is away from the joint, the more load is actually on the joint. So there's a saying that the weight in your hand is no indication of the amount of load that's acting on the joint. So the weight stack saying you have 10 pounds or whatever it's saying really is no indication of the amount of force that's acting on the joint based on the distance of that application of force to the axis. So as you come around and you're extending the knee into the fully shortened position of the quadriceps, full leg extension, you can see that the force of the muscle is still distracted because of the patella, and that's good because it's muscle force at mechanical advantage of the quadricep, but you can see that shearing forces are never lost. So the thing about leg extension is it offers a lot of shear within the knee joint and puts a lot of stress on the anterior cruciate ligament and puts stress on the medial on the meniscus and on the hyaline cartilage. So for people who have been doing resistance exercise their whole life, doing leg extension exercises, they find that this can be quite painful because they're literally shearing bone on bone if there's osteoarthritis present. So that's what I need you to consider with regards to leg extension. It's not just that, it's also about patellar tracking. So the thing is the patella is supposed to stay neutral, okay? So you don't want any rotation of the tibia by trying to manipulate the foot unless this is someone that has an abnormal genetic knee position to start with, whether they have a varus knee or they have a valgus knee. You might have to make alterations in the position of the tibia, and therefore the foot would follow and change its alignment with the patella. But generally in the average human, what you're going to see is you want this patella to line up with the first and second toe, and you want to be working within the neutral position of the patella. Okay? So these are the things that you need to consider. I just want to step back for a second and talk about walking lunges. Okay? The thing that is difficult at walking lunges, which I mentioned, was without understanding how much ground force is going into the foot and the velocity of the movement that you're doing, and not evaluating to see how strong an individual is within the 5 directions of typical strength of the ankle, you can run into situations where the knee is going, in this case for the medial collateral ligament, where they might be bending the knee, and the knee is as I mentioned, is bending in this direction because the foot is not solid to maintain its arch. The tibia falls in that direction, and they're trying to compromise for that or compensate for that by maintaining hip alignment, and they put strain on the medial collateral ligament. The same thing can happen if there's weakness in the lateral stabilizers of the ankle, and there could be a varus stress on the lateral collateral ligament. So here's the thing, okay? This isn't going to tear typically on a first day. This is something that gets strained. And what happens when a ligament gets strained is its collagenous knit starts to get compromised, and this starts to become lax. And as a result of it becoming lax, there becomes more hypermobility, too much movement within the knee joint. These receptacles, the meniscus, they're perfect. And the way that the condyles of the femur sit in it don't allow for deviation, lateral deviation, or irregular torque into the meniscus. So if there is, because the ground forces aren't being absorbed correctly, because the ankle is not stable, the foot is not stable, this is when we start to shear this meniscus and we get irregular joint forces, which can even lead to slight tears in the meniscus in what we call the anterior or posterior horn along this, thank you, along this ridge. Okay, so everything with regards to this hinge has to maintain perfect alignment, and we need to make sure that the forces that are coming in from the ground don't do anything to change the perfect alignment of this hinge joint. Okay, I'm not saying that forces into the knee are always irregular from the foot. Okay, they can be irregular from the hip. If I'm having a lack of stability in the hip, I can get irregular motions of medial and lateral rotation of the femur, which are going to stress the knee joint in the same way that the foot would. But I'm just saying that typically when we're developing young people in the exercise world with resistance exercise, their hips are typically a display of their ankles. And so most of the people that come into my clinic with knee pain, I don't test their hips as a display of the dysfunction that's leading to knee pain. I test their ankles, which are relating to the positional weaknesses in the hip and therefore from into the knee. So that covers off leg extension, medial collateral ligament and lateral collateral ligament strains based on the way that load is acting on the joint. Whether you're accelerating a force into knee extension or you're trying to decelerate knee flexion, doing something like a walking lunge, forces through this joint, through this hinge joint, need to be straight. The old adage is, you wouldn't go sit on your car door. Okay, you sit on your car door a few times, you're going to alter the structural integrity of the hinge. And this is the same kind of thing when you put lateral forces across the knee. So,
okay, so that brings us into our last question. What is the most common cause of knee pain that you see in clinic?
Okay, so to be frank, the most common cause of knee pain that I see come into clinic on a daily basis has to do with foot weakness. So what happens is when I start muscle testing an ankle complex, I typically start with the great toes, the large toe. I take the large toe into extension and I see if they can dorsiflex that toe or hold that toe and make an isometric contraction. Typically what I find is people who are suffering with knee pain cannot extend the large toe with any significant range of motion from the ground, nor can they resist a muscle test, a manual muscle test for the extensor hallucis. Excuse me. So as a result, I check the ligaments of the ankle. So I'm going to the calcaneal, the talocalcaneal ligaments. I'm going to the calcaneal fibular ligaments. I'm looking at the ligaments that support the fibula to the tibia. And what I'm seeing is those ligaments have become lax. So what happens? Because of flexing forward, with the front part of the talus being larger than the posterior part, when someone goes into dorsiflexion, elevation of the foot, there's typically some give within the tibfibular joint. When a joint is side by side, it's not a receptacle joint like a ball and saucer or in the shoulder or a ball and socket like in the hip. It needs more ligamentous support because it doesn't have contact surface support from the receptacle. So when we're dealing with the tibfibular joints, we're dealing with joints that are heavily laden with ligamentation, okay? and there's even an interosseous membrane in between. And so what will happen is I'll do muscle testing and we'll see that there's typically some positional weaknesses. Typically the one that we see the most is the posterior tibialis. Posterior tibialis attaches back on the posterior surface of the fibula and then comes down and attaches into the navicular bone, the cuneiform bones, and into the medial aspect of the cuboid. And so it really ultimately maintains the arch structure of the foot and is responsible for inversion. Okay? So the thing is that when these ligaments are strained because of repetitive strain or pivot type injury that splays the fibula away from the tibia at both ends, what will happen because of the repetitive nature of that type of stress, these ligaments start to become strained. And the way I want you to think about strain is I want you to think about a spring, taking a spring and pulling it so hard that it doesn't have the ability to recoil back to its normal length tension. So it's slightly stuck out. If the ligament is strained, then its collagenous knit is not at the same level of integrity it was, and as a result, neurologically, there is a barrage of input that is being submitted into the spinal cord, and it's what we call an afferent barrage, and it's telling the spinal cord and the brain that it's hurt. Okay, so it's sending in a pain afferent input. Due to the fact that ligaments are only neurologically innervated in a manner that they can input information, they don't receive output information like a muscle does, they can't have any neurological reaction from the nervous system to change their tensile capability. So what I see most often is that there's ligament strain in the lower aspects of the tibfibular joint, or up here at the proximal aspect close to the knee. People could say vice versa, this is proximal, this is distal. Regardless, the thing is that these ligaments are strained. They're sending typically a low volume, like think of volume pain. 10 out of 10 is high volume input pain from the ligament. Low volume would be a 1 or a 2. And someone's walking, they typically don't really notice that there's any significant pain in these ligaments, and they're just operating their daily life as if nothing's wrong. They're playing sports, and then all of a sudden they buckle and they go over on their ankle. And so the thing is that when we have this information coming in from a ligament to the spinal cord, because the brain isn't wired to make change to the ligament, it sends information to the muscle to react to the pain that is being submitted. As a result, there will be over tightness, or there'll be muscular inhibition, and so we'll have positional weaknesses and a lack of stability from the active support system, the muscular system, around this joint complex. So typically what we do is we muscle test to indicate which positional weaknesses are there. We test the integrity of the ligaments through different kinesiological methodologies, and then what we do is we'll end up taping this segment. We'll typically tape it at both areas, but we test to see which ones are necessary. And what we do is we take the ligament's job of maintaining that congruency with its contact surface, and we give it passive support. As a result, changing the length of that ligament allows for that volume of afferent input of pain to be drastically reduced, and as a result, the muscle output from the muscles that maintain posterior tibialis, the muscles that maintain the 5 angles of stability of the ankle joint, are now able to fire, and the patient sees, okay, well, my strength's come back quite a bit in my ankle, and what we recommend is that you continue to input active stimulus into the nervous system by producing isometric contractions repetitively in all 5 angles of the all 5 angles of the ankle, so that the nervous system becomes reattenuated with these active stabilizers, and they become more efficient at keeping this joint actively stable while the ligaments are holding. There's a biochemical side to this, and there needs to be an evaluation as to what elements of collagenous synergy or synthesis need to be expedited, and in applied kinesiology they have assessment methodologies for that, which speed the healing cycle. But typically what happens is people come in and they have a localized area of pain, most often on the medial compartment in the vastus medialis. And once we've negated the stress coming from the ligaments and activated the muscles around the ankle, this localized area of pain in the vastus medialis is reduced significantly, if not altogether. So we recommend stabilizing isometrically the muscles of the ankle, finding angles of muscle activation through isometrics for the muscles in the vastus medialis and the other ones as well, and then go up to the hip and make sure that there are no positional weaknesses in the hip through a kinesiological evaluation as well. But 9 times out of 10, coming into this clinic, I get people that have localized medial aspect knee pain, and we rectify it by correcting this foot. The most important thing for kids starting to learn how to exercise is to learn how to strengthen their ankle before they focus on developing strength in their legs. So that's my Q&A session for today. And if you have any further questions for me, don't hesitate to send me an email, and I look forward to expanding on this subject matter and improving my ability to deliver it to you.
Okay, thank you, Scott.
Thanks, Keenan.
That's great.